Dr. Leanne Mike is a clinical associate professor of pharmacy, and she's the assistant director for education in the Klein Center for Geriatric Pharmacy, Research, Education, and Outreach. She's a fantastic teacher, has done so much teaching, and also does work as a consultant pharmacist in Seattle area assisted living communities. And I have known her for a long time. On my very first scary rotation in the intensive care unit at Harborview back in the early, maybe mid 2000s, she was the pharmacist on our team. She's worked in a lot of different clinical settings and is just fantastic in teaching and clinical care. So I'm really pleased that you're talking to us today about deprescribing, and I'm eager to learn more from you today.
Well, thank you so much for that introduction. I feel such pressure that I don't know I can live up to it. Thank you so much for having me today. As people were signing in, I recognized a couple of familiar names, so good to see you. And for those people I don't know yet, good to see you as well. I wanted to talk today a little bit about deprescribing and have a particular focus on like the how. So like, how can we do this? And I wanted to take a slightly different spin than maybe what historically it has been taught. So I'm hoping to have the audience come out of this session with a couple of really big action items. So like I said, my goal for this session is by the end of this, that you can take away one or two, either a communication or very person-centered strategies that you can implement today in a practice setting that can improve your success in deprescribing. I really wanted to focus on a couple of things, not only because I have only 15 minutes, but because deprescribing is such a huge area. And there's like hundreds and thousands of articles just published in the last couple of years. So I'm going to try to make it into a bite-sized nugget for the audience and have it be something that you can implement right away. So I'm going to follow the what, why, how outline. I'll do a little bit on the what and the why to make sure everybody's on the same page. But I don't know that I want to spend a lot of time making the case. I'd like to think that the case is already made. People know the importance, they know what it is, they know why it's important, so we can focus on more of the how. So that's the general plan. We'll spend the majority of time on the how piece, the implementation piece. So make sure everybody's on the same page. Let's talk about what is deprescribing. I have two definitions on my slide. One of them is more technical in nature, and it is from an article from 2015 written by Scott and colleagues. And deprescribing is the planned and supervised process of reducing or stopping medications that may no longer be of benefit or may be causing harm. And the goal of deprescribing is to reduce medication burden and harm while maintaining or improving quality of life. So really, there's a lot of really important stuff in there. And I think you can appreciate why the body of research is so huge, because there's a lot of different tiny aspects that can be studied and improved upon. Kind of focusing on more of a person-centered approach for, so the focus of our talk is thinking about how I would describe deprescribing when I'm talking with my patients and or their families and or caregivers. And the way I like to describe it is that we're using this process as a way of optimizing your medications. Your situation has changed, your body has changed, your circumstances have changed. Let's use this out as an opportunity to optimize your medications so that we can reduce the adverse effects and potentially maintain and improve your quality of life. So I use that optimizing your medications rather than deprescribing. Deprescribing has this sense of like I'm taking something away, where optimizing your medications has a feel of we're fine-tuning for who I am right now in my, just in my current situation. So that's what it is. The next thing is, why is it important? And the major reasons why it's important is that we all know that polypharmacy is a problem. There's a more recent term coming out in the literature called overprescribing, and that maybe can resonate a little bit more with a lay public. So deprescribing can help address too many medications. It has tremendous safety benefits from an individual personal level. It has economic benefits from an individual level to a systems level to policy level, right? We are reducing adverse events. The patient doesn't have to pay for medications, or payers don't have to pay for medications that may be not beneficial or a patient's not using. So the economic benefits span like the whole spectrum. And there are some quality of life benefits as well. So that's sort of the kind of, let's get everybody on the same page of the what and the why. I hope that I've made at least a convincing argument that this is important. So let's talk about the how. All right, so how can we make it happen? I'm going to use the framework that generally we are using in our pharmacy school to teach deprescribing, and I suspect that, I mean, this is pretty much how the literature is kind of lined up well, and it kind of describes the evolution of how we as, in general have approached this problem. And the process is in general like, okay, let's identify potential medications for deprescribing, and then from there we're going to develop a plan. How do we identify potential medications? There are a lot of tools, there are protocols. I've given you some examples here, using Beers criteria to identify potentially inappropriate medications, using the STOP criteria, which is the STOP stands for Screening Tool for Older Persons, Assessing Older Persons Prescriptions. It's not used as much in the United States, but you'll see it in the literature. It's used like in Europe primarily. So there's tools that we can use to identify medications for deprescribing. And then there's some thought process in terms of like, okay, we've identified some medications. How do we prioritize which one we want to focus on? So there's several different ways we can do it. We can think about it in terms of adverse event. Like, I want to prioritize things that are going to increase my patient's fall risk, or things that might make their cognition worse. So you can do it by adverse event. You can also do it by risk, like high risk versus low risk. So one example of that might be, I'm going to focus on optimizing somebody's anti-diabetic medication so they don't have hypoglycemia, because that's higher risk than, for example, let's get them off the proton pump inhibitor. So in terms of prioritizing, you might choose to do it by risk to the patient. You might also choose to do it by medication class. A couple of medication classes that you'll see, particularly in the Beers criteria, things that are anticholinergic in nature, or sleep aids, benzodiazepines. You can do it by that. Or kind of the low-hanging fruit approach is, if a patient is not taking a medication and they don't need it, that would be a great one to prioritize for deprescribing. So there's a number of different factors. So you've identified some meds, you've figured out how you want to do it. And usually the next step is you're like, okay, we're going to make a plan. And the plan is usually staged. So for example, you don't change 6 or 7 medications. You do it one at a time. Depending on what medication you're talking about, you may need to taper it to avoid risk of withdrawal symptoms. So examples of those would be like opioids, benzodiazepines, other sleep aids. So there needs to be a staged approach and taper as appropriate. Antidepressants would be another one to consider tapering so the patient doesn't have withdrawal symptoms. And then you monitor. You will be looking for adverse events that occur as a part of this deprescribing process. You'll be monitoring for withdrawal symptoms. You may even be monitoring for a worsening or a return of the condition that medication was treated. And as you monitor and you observe, things are going well or things maybe need to slow down, you adjust the plan. So that's usually how we teach it. Like, we come up with the list, we make a plan. Cool. How many of you have made the most elegant, evidence-based plan, and then the patient was not ready to do it or said, I don't want to do it? So your best laid plan doesn't really amount to much if the patient doesn't want to do it or is not ready to do it. So I want to focus this talk on this missing piece in the middle, which is engaging the patient and getting their buy-in. And so the next couple of slides I wanted to share with you include some information from a couple of relatively recent papers that focus on that kind of middle step right there. So again, the best laid plan is not really going to be effective if the patient doesn't want to or is not willing to or can't participate in that. So I wanted to share the results of a couple of different papers with you. These next two slides come from a paper from 2021. In this paper assessed patient preferred language to achieve goal-aligned deprescribing. And this was a survey study, national in the United States, and they took two hypothetical scenarios, one including a statin and one including a sleep aid. And they asked patients, or they asked participants in the study, if somebody were trying to ask you to deprescribe in this, what language would they use would make you more or less likely to participate in the plan? And kind of jump starting all the way to the results is that if we looked at the statin, the thing that made those participants most likely to want to deprescribe the statin was a focus on adverse effects. And the language that was used in the survey was, given your age and other healthcare problems, I'm worried that you are at increased risk of side effects from this medicine. So you can see that a lot of patients that really resonated with them and made them more likely to want to deprescribe. Now, I will acknowledge this was a hypothetical. It wasn't a real life, patient decision. It was more of just sort of like, if you were in this situation, what would make you more likely to change? So we don't necessarily know that what people answered on this survey would translate into actual, decision making in a real clinical situation. But I think it gives us a clue and it can give us a direction to go forward. And I think just in terms of reflecting on how I have approached it in the past, things like, oh, you don't need this anymore. It's extra burden on you to go get your prescription filled. It's one more pill you have to take every day. Those actually ranked a lot lower on this preference scale. And so I think one of the takeaways for the larger group is that, if you think about adverse effects and maybe even pair it with some other things, like, I think you're at risk for side effects and you're also on a large number of medications that I'm worried about, can help maybe move the patient more toward their willingness to have a medication deprescribed. The other scenario is the using the sedative agent. And again, just like with the statin, you can see the relative preference for adverse effects was really, really high. And I think just kind of, if you look at some of the other choices, more harm than good, guidelines suggest that you don't need to be on this, it's unlikely to help you function. Those are much, much lower on the preference scale. And I will tell you that I've certainly used all of those ways to get people off, but reflecting and thinking forward, maybe I really want to focus on the adverse effects. And this was the actual language that was used in the study. This medicine has been linked with side effects such as problems with memory, concentration, balance and falls, hospitalizations, and death in older adults. Wow, okay, that makes me want to think about not taking it anymore. And in this case, I probably would connect the first two preference statements. Like, this is linked with a lot of side effects, and I think we can work together to reduce the dose and reduce your risk. So, even pairing the two preference statements may be really, really helpful. So these are a couple of kind of takeaways from this one paper in terms of how you craft your message to the patient to make them more likely to want to deprescribe a medication. This is not going to resonate with everybody, though. So I wanted to present with you a conceptual framework from another paper, and this is called the Deprescribing Rainbow. And this takes into account like the very person-centered nature of patient's condition. We historically, or at least I will speak on my perspective as a pharmacist, focus a lot on the clinical and a lot on the physical stuff, like time to benefit, the number of medications, or the pill burden, or adverse effects, ADLs, quality of life. And those were sort of reflected in the last survey that we just looked at, survey study we just looked at. But sometimes when those kind of messages from the survey don't really resonate with the patient, we can ask ourselves, what additional things could we talk to the patient about or understand about the patient that could make them more willing or likely to at least consider deprescribing? And so there's a lot of stuff there. I thinking, in terms of how do you prioritize? I think this is just like any other patient-centered care approach where you have to take some time, understand the patient's perspective, think about it from a lot of different angles so that you can kind of come up with a plan that they feel good about and that you feel good about. And this is a free open access article. I've got the link at the bottom if you want to, for the audience who wants to take a look at this in more depth. So wrapping up, deprescribing is a really complex process. I do want to acknowledge that. It has technical and relational aspects. In the beginning, we've talked about the technical, which is like identifying the meds and making the plan, but there's that relational patient-centered aspect in the middle of the process. And so my advice or suggestion to the audience is to use both to increase your deprescribing success. Thinking about how you present options and choices to patients may make a difference. So instead of like guidelines say, or, more things like, I'm worried about the side effects of this medication. And that kind of follows into my next summary slide, which is focus on the adverse events when you're starting the discussion. That doesn't mean that it ends there, it's just an opener. And then for those people who are, just need a little bit more time, use some of the possibilities within the deprescribing rainbow to meet people where they are in the deprescribing conversation. So whatever we can do to move the needle. I've included on the slide here the tortoise and the hare, just to remind everybody that this is not a sprint, it's a marathon. It takes time, it takes patience. You need to have a trusting relationship with a patient. So just give yourself some time. Use the tools that are available to you, and just stepwise, slow and steady wins the race, right? So just as a reminder to the audience. And then lastly, quickly on the ongoing areas for work, future work, is I wanted to call your attention. There is some work in this area, but I think we're going to need more about more work in this, and that is exploring deprescribing strategies in older adults from various cultural and ethnic backgrounds. Most of the work to date has been done in the United States, Canada, and Australia with a primarily white population. And so thinking about how we might even harness the deprescribing rainbow to think about how we can meet the needs of people who have who come from different ethnic and cultural backgrounds. And as a reminder, looking at the demographics, we're going to have a larger number of who have been historically more minoritized population in the United States. So thinking about this now will help us be prepared to take care of their needs in the next decade or so. So with that, thank you so much for your time. Phew, that was a lot in 15 minutes. So thank you. I think I might have gone over, so I apologize for that.
No, that was great. And, I took up time with the introduction, so you were right on time. Exactly right. We have time for some questions. If anyone has any questions or comments, successes or challenges you found with deprescribing, but feel free to unmute to ask questions. And if for some reason you cannot unmute, you're welcome to toss your question in the chat as well. Folks are quiet. You answered all the, oh, Sarah, yeah, feel free to unmute.
Yeah, thank you for a really great presentation. And so I'm a student, a nursing student at UW, but I also work at Department of Health, and I work closely with our antimicrobial stewardship pharmacist and epidemiologist. And so this is one area where we're always struggling, and the terminology we use is antimicrobial stewardship. And so it was really helpful to hear the term Deprescribing. But can you talk a little bit about maybe strategies you've used when looking at antibiotic prescribing?
Yeah, so I thank you for your question. I think optimizing medications is kind of a really great overall way of managing, because that's really what antimicrobial stewardship is about. That's why de-escalation of intensive care therapy is about. So in my humble opinion, optimizing treatments, medication, therapies for your current condition, for your current, goals of care, for your current status, to me makes a lot of sense. And I think most people can get that. We're optimizing your treatment plan. So yeah, I think antimicrobial stewardship is, kind of an academic kind of term. Same thing with deprescribing. So thinking about ways we can connect that with the public is a really important thing that we can do.
Yeah, I agree. Thank you for that. And I'll take that back to our team, because I have struggled over the years with that terminology of stewardship, and how do we make it so that it's something that folks can relate to. So thank you.
Mm-hmm. All right, you're welcome.
Other questions? I have one if no one has one. What seems to come up a lot, especially we have a lot of folks who work as part of primary care teams who are on these sessions. And one thing that comes up a lot is, what if someone else prescribed the medication and you're the primary care doctor? And have you seen, or can you share best practices of like how to manage that scenario where it looks like something needs to be deprescribed, but there's this inertia that comes from like, oh, this other person is managing it?
Yeah, I think you really bring up a great point, in that this is one of the obstacles, barriers, of challenges of deprescribing is like, I don't want to touch the cardiologist medications, the specialist medications. And, a couple of things that the literature will tell you is like, somebody needs to take ownership, which is easier said than done, right? But I think one of the other efforts afoot is that there is more outreach or work within prescriber disciplines and specialties to bring the word out. So I know that I have seen studies with cardiologists, with psychiatrists, to help them understand about the process and the importance of deprescribing. In terms of how to implement a plan, I know I focused on implementing today. I don't have a particular best practice, except maybe communicate directly with that. And I know there are a ton of obstacles and barriers with that sort of direct communication. But yeah, a couple of things the literature tells us is somebody needs to take ownership of the whole thing, and then sort of like some outreach and education of all prescribers. And that was on kind of my future direction slide too. Yeah.
Fantastic. Yeah, I think that's a really important point, like getting the word out to everyone who prescribes, but also advocating for our patients, because we might see things that other folks on the team don't see, like maybe someone's falling or having an adverse effect from the medication, or we see them more often and their blood pressure is running low and they're dizzy, whatever it is.
Right.
And being able to communicate across teams and feeling empowered to advocate for the patient and have those discussions.
Yeah. Well, it's a marathon, not a sprint, so we'll keep working at it.
Yes, I appreciate this talk. I think it's great to have a framework, because it can be overwhelming when someone's many, many medications to know where to start. So I really appreciate that.
Thank you.
All right. Well, I think